So obsessive-compulsive disorder is something that we've actually found is a lot more common than people seem to know. It's really hard, though, because if you look at the criteria for obsessive-compulsive disorder, a lot of people with Prader-Willi say they don't have obsessive thoughts. Well, really? Because the fact that they ask the same question over and over tells me that they are thinking about the same thing over and over. And I think it's really important to see how these behaviors affect a person, and more importantly, their family. Because most of you will say, my kid with Prader-Willi seems okay with these things. It's really hard for me to manage these things day in and out. The thing that they need to, and it's not like living with Martha Stewart. Your house doesn't look like House Beautiful. It looks like an episode of Hoarders. So it's like, I've got stacks of comic books. I've got skeins of yarn. And we've actually looked at some of the data. I'm actually going to report some of the stuff that they hoard and what they hoard. And more about, importantly, the new DSM-5 is actually going to exclude Prader-Willi syndrome from hoarding. They feel like having that diagnosis, you shouldn't be able to be diagnosed with hoarding as well. We feel like that's completely wrong. We feel like this could be a window into why people hoard. And most people will say, my child is so averse to get rid of anything that they have. So if your kid's room is really neat, trust me, it's either because you're doing a lot to get rid of that stuff, or that's not an issue for them. They have some other repetitive behavior. So how does hyperphagia relate to anxiety? Here we have a young man with Prader-Willi syndrome. He's got lovely fruit, and he's sitting in a lovely tropical setting. But I can tell you, every time I see this young man, he literally scans my entire office. I watch him. It's like a robot. He's like, always go, Chris, I have no food in my office. Oh, I know that, Elizabeth. So you might as well stop looking. And he's like, oh, yeah, no, I wasn't looking. Great. So for us, the fact that we've known him since he's a teenager and now he's in his 30s and he's living very successfully in a group home. He has a job. He has a girlfriend. He's incredibly independent, sings in a boys' choir. He really has a great life. But the deal is it took that group home residential setting for him to be able to be safe with food. And I think that's important. It's not true for everyone, but for some people, his mom, he's the youngest of 4 boys, she can't manage him day in and day out. They go on trips, and she literally has I love this, an alarm. When she comes to the hotel that stay at the end of the street, she has an alarm at the top of the door. If the door is opened, the alarm will go off and he'll know. And she actually has, the first time they came, he did get out and he was in the lobby. I love this. So she told him that she was going to be putting an alarm on the door, and he goes, you don't need to do that. Oh, Chris, it's not for you. It's to make sure no one comes in the hotel room in the middle of the night. And he was like, oh, sure enough, an hour into sleep, she hears the alarm. And I love this. He's standing at the door and she goes, Chris, where were you going? I wasn't going anywhere, Mom. I thought I heard someone coming in. He's nothing if not crafty. And she said, well, great. Close the door. It's all good. Come back to bed. Never been an issue since. Now that he knows the alarm really does work and she really will wake up, he's good with that. So autism, how common is it? A lot of people will say that autism is either doesn't happen at all or there's some overlap. We find that obviously those with UPD are more likely to have, an idea they have autism, but we actually found more people who have deletions and imprinting mutations who also have autism. So it's not just people with UPD. I think the deal is if you see enough people, you'll start to see that there's some overlap. And it could be there's an overexpression of that maternally imprinted gene, and they also are more risk for psychosis for people who have UPD. But again, we've actually found some people with deletion and imprinting mutations who also have psychotic features. So the deal is I think we need to say, you don't need to worry about every time your kid says something like, I believe in Santa Claus, that, oh my God, they're psychotic. You have to kind of know what to look for. And it doesn't look typical in people with Prader-Willi syndrome. And I'm going to talk a little bit about what it does look like, because I think for some parents and actually professionals, they're missing the boat. They go, oh, that's just Prader-Willi syndrome. Not so much. So the overlap, the repetitive behaviors, anxiety over novel situations, they react very strongly to new situations. Even if they're positive, Disney World can completely melt them down about anything. Restricted interest. Most of you will think your kid is interested in something extremely odd. We have kids who are obsessed with the musical Annie. We have kids who are obsessed with, things that you just think to yourself, tractors or trucks or trains. It's like there's some interesting things they're interested in that are not typical for people their age. And it's not just about food. They also have poor social cues. They sometimes have a hard time reading what you're feeling, what they're feeling, and what others are feeling. So I think that's the thing that kind of overlaps with autism. Also perspective taking. Sometimes at the end of a blowout, they're kind of like, wow, why are you so upset still? Wow, it's hard for you to imagine that they can't see why you would be upset. But also scripted speech. If you listen to what they say, it's incredibly repetitive. They ask the same question. My favorite is do you have any kids? Yeah. How old are they? 13 and 16. What are their names? Bennett and Caroline. Yeah, I don't like those names. I think you should change them. No, okay. So all of a sudden it takes a really strange turn. So is that social? Yeah, but it's a little more scripted and controlling than other people. But needing to follow routine schedules. Sensory issues. A lot of people will say, wow, I don't think they have any sensory issues. I had a young man who came up to me. I shook his hand, and it was so sweet. He just puts it right up to his face. And he goes, oh, he kissed your hand. I go, no, he just wanted to smell me. And it was fine. But for him, he constantly liked to pick up pins that people had touched or, walk up behind people and smell them and things like that. And the deal is I think if we don't know what it is, it's really hard to intervene. So I think it's important to figure out what these things do and what they kind of mean and how we can intervene. So autism in PWS definitely looks different. More common in those with UPD and boys. The poor social and communication skills as we do these really long kind of autism interviews, you find that they have a hard time when you ask stuff like, so tell me about when you feel happy. And they'll say, smile. I go, well, okay, it's not word association here. Just what makes you happy? And they're like, happy. I'm like, okay, yeah, got that. And I think they have a harder time reading those kinds of things. So those kinds of things I think are really important. Restricted interest, poor eye contact. Most of you will notice that some kids with Prader-Willi really have great eye contact. Other times they have really fleeting eye contact. They will look at you, and then when you look at them, they look away. And so there are things that overlap. We also found, like I said, again, people with deletions and imprinting mutations also have autism. So I think we have to be careful in not saying it's only people with UPD. And again, I think you have to use the gold standard for actually rating these behaviors. You can't just have your pediatrician go, your kid's kind of odd. I think they have autism. I think you really have to do a very structured interview and assessment to see if that is actually the case. So as far as other psychiatric disorders, ADHD is a lot more common in Prader-Willi than we thought. But what you don't see is the hyperactivity part. These kids are not buzzing around out of their seat, touching other people. It's more this idea they have a hard time to stay on a task. It's hard for them to actually complete tasks. And like if you give them like let's say 3 steps, go brush your teeth, put your books away and get in bed. They hear the first thing and then they're like, what did you say? It's like they really have a hard time following multiple steps. So again, those with UPD are more likely to have an ADHD diagnosis than those with deletion, but also lower age and BMI for those who meet criteria. So younger kids and then also lower BMI. It could be actually the stimulants that we give them for ADHD also lowers their BMI, or it could be that because they're more hyperactive, they're thinner. So we don't know, but it's kind of fascinating to think that actually kind of changes what they look like if they have ADHD. So again, less hyperactivity, younger. Common medications do help, but they do have some side effects. So I tell people it's really important to look at things like nervousness. Irritability really increases, and this is true in the general population who takes stimulants. I actually have a 16-year-old who takes Vyvanse, and it's been an amazing drug, but when it wears off, super cranky. So it's like that is true of our kids too. So I think it's really important to say, is a stimulant really the thing that they need to take, or are there other drugs that are non-stimulants that might work just as well? There are some better choices, but I also think you have to separate anxiety from attention. A lot of people tell me my kid is inattentive. No, it's almost like there's a gerbil in their brain just going around and around and around, and they have a hard time focusing on outside stuff when they've got so much kind of stuff going on in their head. There's a young man that we follow, and I've known him since he was about 7. He's 17 now, and I love what he said. He was talking about something, and his mother says, Patrick, I don't know what goes on in that head of yours sometimes. And he goes, Mom, it's a mess up here. I go to bed thinking about things, and I wake up, and I have felt like I have thought about them all night long. And I thought, wow, it's pretty amazing that he can articulate that that's what it feels like. But that's exactly what he said. It's not attention. It is actually thoughts about things. And it is things that most of us never even think about. So as far as motor and vocal tics, again, about 30% of the people meet criteria. Definitely more males than females, lower age, and also, again, lower BMI. And motor tics and ADHD kind of follow hand in hand, so most people who have one a lot of times have the other. It's not Tourette syndrome. It is really just a motor tic or a vocal tic. Things like clearing their throat, touching their face. Some kids will start the same sentence over and over, and they'll go, oh, they've just got a speech impediment. It doesn't sound quite right to them, so they'll also use repetitive phrases. And it's really funny because sometimes they sound like they really are very articulate, but if you listen to their words, you'll notice they say the same phrases over and over. So again, there's some pretty interesting things that we need to be able to kind of tell more about. It's definitely more common than we thought, sounds, and I think the deal is a lot of parents don't recognize their kid has any of these things. I don't think a lot of professionals do either, so I think we need to get better at figuring out what they have, what they are, and how we can treat them. Even things like wringing hands or touching their hands together. You can even say stuff like, put your hands in your pocket. You don't tell them to stop doing the behavior because that does not work. But you can give them a competing behavior, so at some point, especially if they're kind of like distracting others, they can find a way to kind of bring it down a level. We had a young lady who'd like to play with string, and her teacher was very upset with her because she said it makes her look disabled in the classroom. And I kind of thought, she's extremely in the normal range as far as her cognitive functioning. Even socially, she's pretty good. So all we ended up doing is saying, instead of getting rid of the string, which made her feel focused and able to kind of deal with the day-to-day stress, if you can keep it below your desk where nobody can see it, you twirl away on your string, girl. It won't make a big difference at all. And for her, it made her feel so much calmer to have that close by. Depression is really uncommon in this group. I mean, we keep thinking that there must be, since anxiety's high, must be a lot more depression. There's really not. So about 8% of the people we have seen, and it's mostly past episodes of depression. But the neat thing is I think if we could actually figure out who is at risk, it seems to be people who are maybe a little higher functioning cognitively, but no gender or subtype differences or hyperphagia differences. So again, older age, I think we need to really look at adults and see if they're at risk for depression and see what we can do to kind of help manage that. And I do think the people who seem to know that there's a little bit of a disparity, I'm not like other people, I don't fit in, are more likely to feel depressed. So I kind of tell people that transition to adulthood is a really good time to look at what are we doing to keep our kids connected and kind of engaged versus just kind of sitting in their room and being isolated. And again, a higher BMI for those who meet depression criteria. So we talk a lot about emotional eating, but you may be more likely to be overweight if you actually meet criteria for depression. Some of the studies about psychosis, I mean, I have so many parents who have kids with UPD who come in and go, oh my gosh, is my kid psychotic? I'm like, no, and they're just fine. And they're like, but these studies that have like had these huge prevalence rates, like 80 to 90% of those with UPD will become psychotic, or I mean, that really freaks parents out. And I kind of feel like, why are we saying these kinds of things, that it's going to happen to everybody? Because I think it's really unfair. We are seeing, I mean, out of 200 and some odd, 226 people, we've had 4 people with active psychosis and 18 with past history. So it doesn't look the same as it does in people who have like schizophrenia, because a lot of parents are really concerned that it is schizophrenia. Having worked in the psychiatric population and in a psych hospital, schizophrenia is pretty depressing because most people who have it have this kind of downward spiral. Not true with our kids with Prader-Willi syndrome. Most of them actually seem to resolve it pretty quickly, and it always is in conjunction with meds and a new support system. So you kind of figure out what's going on, and it looks really different. So I tell people, if your kid stops eating or sleeping and they look disheveled and kind of not groomed in a different way, then you may be seeing sometimes the beginnings of something that's psychosis. And it almost always is precipitated by extreme anxiety or depression. So I kind of feel like we need to be aware that just because they start, saying things like, one girl kept saying that she saw her teacher driving around town. Is that troubling? Yeah, maybe it's a little odd. Her teacher didn't even live in their town. But I think we kind of have to realize that sometimes that mind's playing tricks on you happens to a lot of people. It's when it starts having some behavioral changes that we need to be aware that it could be a problem. Some of the medications that work really well are things like Risperdal, Depakote, and what's so amazing is sometimes within just a couple of weeks, they can be completely bounced back from these episodes. And for the people who have UPD, who have these psychotic episodes, what we're finding out is once they bounce back, they're even better than they were before sometimes, and that is not true in schizophrenia. So I tell people, don't freak yourself out. Just be aware that there are treatments at work, and if you have to do psych hospitalization, then you need to do psych hospitalization. And you need to make them aware that of the food issues and the other things, but at the same time, these medications work extremely well and really fast in Prader-Willi syndrome. So what does it look like? Again, late teen years to early 20s, I think, is a really critical period. I think we have to be kind of aware, and some occur later, precipitated by stress. When people say that they're lose a friend, a boyfriend, or making big diet and school changes, like transitioning from school into like vocational or adult placement, I think we have a lot more issues. End of school is a big loss for them. People don't realize they're graduated, yay! You get a whole new set of problems, and the loss of structure, routine, friends, support is huge. So we see a lot more depression and anxiety, and sometimes that can actually end up being psychosis. So it looks disorganized. Again, changes in sleep, diet, delusions that they already have become much bigger. And so I think we need to be on the lookout and monitor for these things, especially when dieting and other stressors occur. And I tell people, Act quickly. If somebody tells you, just Prader-Willi, if your gut says this isn't Prader-Willi, this isn't something I've seen before, you need to keep asking people to see your kid and to evaluate your kid until you can get help. There's nothing worse than when parents say that somebody told me he was fine, and then a couple months later they have really gone completely downhill. I think you have to kind of go on your gut instinct. Parents know their kids better than anyone else. So what do? Again, trust your gut. Don't chalk it up to this PWS behavior. Look for losses. For almost everyone we saw, changes in some kind of situation is what precipitated this. And again, keeping them on a schedule, consistency can help a lot at recovery. If your kid is sitting at home all day, they're not going to recover very quickly. As quickly as you can, get them back into day-to-day schedules. Hooking up with grandma, going to church, social clubs, anything you can do so they can be connected again. And again, sleeping, eating, and getting regular scheduled activities. And I think we need to really educate our psychiatrist about what it is in Prader-Willi syndrome. It does not look the same, but it's something that we need to take seriously. Again, 2.2% of our sample has had current criteria for psychosis, and only 9% has actually had a previous psychotic episode. And if you look at that, they're not all UPD. It's interesting how many people who have deletions actually also have psychotic episodes. Love interest, losing a boyfriend is actually a big deal to them. So my thought is if that happens, you need to kind of think about what plan you need to put in place to kind of make them bounce back. Obsessions with other people, somebody loves me, somebody's, looking at me, those kinds of things. A lot of our young ladies want very much to have babies, and they're very obsessed with being pregnant. And there's nothing more scary than when your daughter tells you, I think I'm expecting a baby. So again, it can be an obsession, but it can become incredibly fueled by a lot of things, and it becomes very intense. Slights by others. You know that these guys sometimes can hold a grudge like nobody's business. This person, was mean to me 10 years ago, and every time they drive by their house, I still hate that lady. It's like, wow, they can really hold a grudge. So I tell people those kinds of things can really bloom into these really odd kind of psychotic delusions. I love the fact that almost 60% of our folks are on no psych medications of any kind, but 26% are on an SSRI, 11% are on an atypical antipsychotic, 6% are on a stimulant, 9% are on an anticonvulsant, and it's not for seizures for the most part. It's actually for behavioral control. 2% are on anti-anxiety, which don't really work well in this population anyway, and about 2% are on wake-promoting agent. And my thought is for the people that we see, it's pretty amazing to me how many people are not on meds. And this has actually kind of changed. This is actually after we saw them, so probably I bet it's more like 70% aren't on meds when we see them. And then after that first visit, when we talk about some recommendations for medications, some of them do get on meds, and it can make a life-changing difference for them. So as far as treatment of psychiatric symptoms, things like outbursts, tantrums, skin picking, irritability, those are kind of the things that people will say that the medication's prescribed for. Again, the common medications that we see used in this population, Topamax is used, and it's sometimes used for skin picking, though we haven't found it to be very effective. Things like Depakote, Risperdal. A few people are on Geodon and Abilify, and our experience has been that those medicines don't really work very well in this population. Sometimes we have more behavior problems with these kind of atypical antipsychotics. Things like Lexapro, Prozac, Celexa. Some have been on Paxil, Zoloft. There's some pretty amazing drugs that work really well, and in general they work well in really low doses, much lower than you would see in the general population. And things like Lamictal and Tegretol we also see. Again, that low doses is so important. If you get a psychiatrist who goes, well, most kids are on this dose, we'll just start them out on that. Sometimes they get way too much medicine too quickly, and all you see are the side effects, but none of the good effects. So I think we really have to kind of figure out, starting out with the very lowest dose and trying to figure out what they need to kind of help their behavior. And again, some people have to try multiple meds. I like to think there's this great way that, we don't really know what works. And for some people, the thing that we think works won't work as well. Some things to know. So there are some actually subtype differences. I actually looked at this data right before I came, and it's really interesting. So many with deletion seem to do well with an SSRI, like Celexa, some with Lexapro. Prozac seems to be a little bit activating, so sometimes we find that the kids who take Prozac, they seem to do okay, but they seem to get more agitated by taking that. So we kind of feel like there are some drugs that seem to be pretty good, especially the young kids. And if you're on Prozac and you're an adult and it works well for you, I always kind of say, if it's not broke, don't fix it. But a lot of people, like you said, kids really get activated on it. And we've even had some adults who have gotten really activated on Prozac. So I kind of feel like you need to be careful what you start out with. That idea, like that puberty threshold, yeah. Not, and it doesn't matter whether they've gone through puberty, but that's kind of the level that we say we don't. And I would say, like I said, even for adults, I still think Celexa usually is a better option than Prozac. So we have a lot of people who've been on Prozac for 10 years, and I'll say, how's it working? I don't know. Well, if you say I don't know, it means it's obviously not doing much. And so I feel like we need to be really careful about evaluating medicine. Some people have been on, we've seen probably about 10 people who've been on anti-seizure medication since they were infants, and they're still on them in their 20s and 30s. And I'm like, do they have seizures? No. Wow, so is that the reason they're so sleepy and they're lethargic? And I'm like, why does no one reevaluate what they're on? But a lot of people think, well, if they've been on it for so long, it must be okay. Maybe not. So I think we have to be really careful about that. But again, they need really low doses. Those with UPD seem to metabolize more slowly, our experience has been, and they're more likely to have mood activation. For the people who have UPD, I think you have to be really careful with meds. It doesn't mean that you can't try them. It just means that you have to be careful of the mood activation, and that even low doses sometimes can be too much for them. And I think sometimes those with UPD are more likely to need a combination of drugs. Usually an SSRI alone is not what we see. It's usually a combination of antipsychotic and an SSRI. So they seem to need both of those. And people always go, but I don't want to put them on more than one medication. Well, right. But neurochemically, we know they're different. So I think we need to treat what we see instead of just worrying about meds. And, the deal is for some of them, it is life-changing to be on meds. We've had parents who've reported in a couple weeks, I cannot believe how much more calm and soothed my child is than they were before. So as far as age and genetic subtype differences, some young children can take medications. But again, I think at that point, and we've had kids as young as 6 who've tried an SSRI low dose, I think you really have to work carefully with your mental health provider to make sure that works. Those with type 1 are less likely to be on meds, which is kind of interesting to me. We know that as they become adults, they seem to mellow out a little bit. So again, they're less likely to be. And these are just some of the things that we kind of sometimes see. I really think that idea that people might be slow or low metabolizers really needs to be looked at, because we are finding more and more people who seem to have really odd responses. We actually had a young lady who was on just still kind of 1.25 milligrams of Risperdal, which is like, I don't even know, it's like 0.0125. It's like literally like a hundredth of a normal dose. Within 3 days, she started becoming catatonic. It just doesn't happen. And actually, as I looked at I looked that drug up to see what the prevalence rate was. It was incredibly low. It was like 1 in 40,000 people have that response. Well, she had it. So again, I think we have to be really careful. And some of these drugs actually come in liquid formulas, and you can dose them so low that it's just amazing to me. And those are some of the doses that work the best in kids with Prader-Willi syndrome. Things that we need to watch for: drug interactions. A lot of people say if 5 milligrams is good, let's go with 10. I say if 5 milligrams is working good, let's stay at 5. So I think it's really important to kind of not push that envelope. And again, starting 2 interventions at once. We've had several psychiatrists and even physicians who prescribe 2 medications to start at the same time. If it doesn't work, we are not going to know why it's not working, or if it does work, it may have been that one medication would have worked just as great. So environmental changes, charting progress, documenting dose. I'm going to actually talk a little bit about a kind of a diary that people should keep, because for a lot of people, it's hard to remember when you started it, when you gave it, what happened, and sometimes people will say, well, it's not working anymore. But I actually pull up emails from you when you started it saying, wait a minute, it was working really well. And sometimes we can see significant changes that parents will stop noticing. So I think you have to really document. It doesn't have to mean you have to journal. It just means you have to do something where you can tell what behaviors are being targeted, and tell people, target what you can change, not what you can't. I had a young lady recently who was started on a stimulant for appetite control. Well, within a few months, she had a huge psychotic break. What could it be? And I love the fact that after we got her stabilized, her mom said, wouldn't it be great if we could actually put her back on that for some appetite control? I go, are you kidding me? So I think we have to be really careful. Appetite control is not something we see from the medicines that we use. So I think, we can target irritability, we can target some of the other things, but what we can't change are some of the core features of Prader-Willi syndrome. There may be medications that will do that in the future. We're not there yet. Medication diary. Lauren's got some handouts that she's going to give people at the end, and actually has some of these little tools that you can use. I think they're really helpful to help you get focused, and when you meet with your provider, to be able to say, this is what we're giving, this is what we've noticed, this is what, and that kind of stuff. Because sometimes, and you got like 20 minutes to kind of crank it out, and sometimes you'll forget, and you'll go, oh, I meant to tell him Well, this will kind of help you do that. And I think it's really great to share with your prescribing doctor all the other things that you've noticed, especially if you do notice appetite changes or irritability. Some people will say, these things are good, these things not so much. So it's kind of like we don't want to keep adding more and more medicines to treat the not good. I think we just have to pick the right medicine to treat what we're trying to target. Medications are not the cure-all for behavior problems. I tell people, if you are not consistently parenting and you don't have all the other stuff down, all the medication in the world is not going to help you out. So it really is a combination. And group effort is the key. Working with therapists, schools, doctors, and getting the family and community in balance. Everyone needs to participate. A lot of people will say, I'm doing it right. The husband not so much. Grandparents not helping. You have to kind of educate and get people into the mix, because if it's an inconsistent environment, then the kid with Prader-Willi looks for the weak link, and they know grandma will feed me a cookie if I ask her. So you just have to know what everybody else is doing. A lot of people with Prader-Willi syndrome can get very upset very easily. I think we really need to allow them to calm down and to be able to kind of document when they're upset and what we can do to help. When you can let them decide when they're ready to return to the situation, because if we see some escalating behavior, what we do a lot of times is say, well, you look like you're getting kind of upset there. Maybe you can, you want to take a break? I always say, don't call it timeout, because that's negative. That's fine. You want to take a break? Want to hang out for a little bit? Then you let me know when you're ready to get back to it. A lot of times when you do that, they feel more in control and they are able to go take a break and come back to it. Do not rehash. We've had teachers who've had a kid who's had to be sent home and had to go home from school, and the next morning they'll come in, that kid walks in and they'll go, well, I sure hope you don't have a day like you had yesterday. Well, let me tell you, that kid is ready for it at that point. You have rehashed a situation that is only going to upset them. So I tell people, you don't need to process it. It's not group therapy. We don't need to talk about it. Every day, you take the slate, you wipe it clean, and you start over. And the deal is you have to kind of return to balance. You don't have to be right. Some people go, no, I'm the parent. I have to be right. If you need to be right, you will find that your child has to be wrong. They don't really deal very well with that. So I think it's really important to kind of level the playing field and come up with a compromise that both of you can live with, so that you can both be kind of winners in this situation. Yelling does not work. Arguing, sarcasm. We have people who say sometimes the meanest thing. I'm just kidding. No, you're not. And it's not okay to do that. Trying to get them to give in. Again, they can hold their own and get the last word in every time. And also trying to reason with them. We have teachers who will walk over to them when they are screaming and yelling, and they'll go, well, Johnny, if you'll just get up, I'm like, they are gone at that point. There's no reason to try to reason with them when they're that upset. Or having to have the last word. Sometimes you can get them calm, they're back, it's all good, and the parent will say something and you just go, what did you just do? They want to get that last word in. But again, holding a grudge or personalizing. A lot of people will say, my kid is doing this to me. Teachers a lot of times say, this kid is just trying to get under my skin. Trust me, they don't care enough about you to get under your skin. So you need to get over it, and if you can't handle that day in and day out, you need to maybe transfer that kid into another classroom, because we have teachers who, when I call them about a child with Prader-Willi syndrome, they go on this laundry list of all the things that this kid does that makes them crazy, and I'm kind of like, well, can you tell me anything good about them? Well, I mean, I'm like, so I think it's really important for you to help teachers and other people realize that these guys have so many redeeming qualities. And yes, are they perfect? Probably not. But they are amazing in so many ways. So if you hold a grudge, trust me, they will too. Containment, trying to lessen the behavior. Ignoring really works. Limiting your response. If you escalate, trust me, they will escalate even more. Verbal praise is huge for them. Oh my gosh, look how well you're sitting in your chair. Look how well you're doing that. They love to hear that. And give them a reinforcement schedule. We have a lot of teachers who say the behaviors are unpredictable. I just don't know when he's going to go off. And I'm watching the kid escalate. The teacher has nothing to say to them in any positive way. All of a sudden they're getting agitated. They're in their chair. They're moving around. And it's like the behavior escalates. But I kind of say you put them on a regular schedule so they're constantly reinforcing what you want to see, and you pay attention to desired behavior. Most people do exactly the opposite. They only reinforce the behavior they don't want to see. Stop doing that. Stop yelling. Stop doing it. My gosh, look how good you are right now. I am so proud of you. That kind of stuff. Visual schedules are really good too, and we actually have some examples of those kinds of things. So they need sometimes help with kind of getting the steps. It helps remind them. It keeps them on task. We use them a lot. They put stickers beside it. At the end of the time they spend with us, they get to pick something out of the prize box. But these kinds of schedules work amazing for kids and adults with Prader-Willi syndrome. And even when it comes to job training, visual schedules are amazing in getting them to stay on task and keep them moving. Getting ready for school and realizing that consistency is the key to changing behavior. People will say, oh, I tried it for 2 days and it didn't work. Well, how many times have you tried to change behavior in 2 days and found that it made a difference? I kind of feel like what we need to do is think about using something over and over and realize that with less stress, your family will operate so much better. Yeah. Mm-hmm. Yeah. Yeah. On occasion, and I kind of feel like, you have to there are so many individual variabilities, and so for some people, visual schedules don't work well. We're kind of amazed at the people who don't use them when obviously it works well. Sometimes verbal instructions get lost in their head. Like you try to tell them and they're like, yeah, I remember the first couple things. And so that's the reason these kinds of visual schedules work. But if that is the case, then you could do it more kind of like unstructured so that, the flow of things may be the same. But time is something you don't usually need to say. If you say we're going to do this at 11 o'clock, well, my gosh, you have to make sure that 11 o'clock you're actually doing it. Well, that doesn't happen in the real world. So I think it's more important for the order than the time. So don't put times. Order is important. A lot of people have talked about having a mantra. Go with the flow. Somebody this morning said, things change. You need to come up with things that help your kids know that they are going to experience change, and it is important to be able to go with the flow. Does it mean they're going to like it? No. And that's okay. But they need to know that change is going to happen. You cannot control that. And again, a little change will do you good. And it is important for you to incorporate that into your life because the real world will not accommodate all these things that we're doing in the homes unless we start to slowly but surely kind of build on being consistent, but realizing sometimes recess is going to get rained out. Sometimes this isn't going to happen because of something. So I think if we constantly get them used to doing the same thing every day, they will become very intolerant to day-to-day change. Yeah. Yeah. Mm-hmm. Right. Yeah. Yeah. I agree. And you have to kind of balance. Yeah. And the idea that they're going to be okay. And that's true of anybody with a kind of obsessive, rigid personality. Once they realize that they will be okay when things change and that you will be okay when things change, I think that is important for them to do. So, yeah, all that's important. And ultimately, the more you do it, I mean, think about it. I don't know about you guys, but when I was younger, I didn't like change so much either. The older I've gotten, the more I've realized there are very few things in life that I can control. So I control what I want to or what I can. And the things that I can't, you just have to go with the flow. So, I mean, it is hard. And these guys don't like change. But that doesn't mean that that's okay all the time. You do have to get them so that they can get used to some degree and be okay with it. I use this slogan a lot because I find it so true. Hard now, easy later. So a lot of people go, oh, I just don't want to argue with my child. I just had a mom on Wednesday right before I flew up here. She goes, I don't want to hear her argue, so I just give in. Is that the reason that she's punching her 7th grade teacher every day? It's like she doesn't realize that in giving in, you are giving control to the child. And I think it's really important for you to realize it is work, but if you do it on the front end, it is easier later. And I think we have to kind of let people know that you have to be able to be okay with that. And it's also okay to know that some days you are not going to feel like that, and that's okay too. We're not perfect. Nobody's perfect. I do not have 2 perfect children, I can assure you, but I do feel like we have to be really careful about doing what we need to do, and it's hard work, but it really will make a difference. Your attitude to like activities and routines are really important. So I tell people, so pretend you're on an airplane. All of a sudden you find out that an engine's out. I can tell you right now, if that stewardess comes out and goes, oh, well, we're going to be experiencing a little turbulence today, and free drinks for everybody, and everybody should go ahead and get buckled in because of the turbulence and stuff, but it's going to be great. You're not going to worry. But if that stewardess comes out and she's freaking out and she says, oh my God, we're all going down, the entire plane is going to be freaking out. And for a lot of parents, that's exactly the kind of affect that you have. And I have had several research assistants, and Lauren is great at that. I will sometimes kind of hear a little ruckus, a little kind of raising of voices, and Lauren, it's great. We're almost done with everything. And it's like, I kind of know her well enough to know when that's true and when that's not true. But I love the fact, because once you do that, the kid goes, wait a minute, is it going great? They can get back on task. So it's really important for you to kind of show the affect that you want to have. Again, that slow, repetitive behavior, not motivated, you can put a reinforcer on the hand. We had a young girl who wouldn't put on her shoes. Mom goes, I cannot get her to school on time. She won't put on her shoes. I go, let me tell you this. Your kids should be dressed before they eat breakfast. And let me tell you, those shoes will be on. Within 2 days, new routine, all good. Again, negotiating and arguing with your child really leads to more bargaining, more manipulation. You have to be very clear about the expectations. I like to actually put them in writing. I'm a big believer that contracting, especially for people who can write and read pretty well, it's a really good idea to do that. And you have to do them before the situation arises. You cannot wing it. People go, I'll just figure it out. No. Your kid with Prader-Willi cannot handle that. You have to know ahead of time. If you know you're going to be in a stressful situation, you have to know what the expectations are, what a good thing will look like, what a not so good thing will look like, and how you're going to make that happen. If an argument starts, do not engage. I have people who often do the very thing that they don't want their kid to do. So I think it's important not to argue with them. And it's funny because we even had a graduate student who was doing some testing, and the young girl he was testing, he didn't want to use a visual schedule. You don't need that. It's not important. And within a few minutes, she was really upset. She comes to my office. She's kind of almost tearful, and she's upset about something that happened, and she wasn't sure about how things were going to go. And she starts telling me her side of the story. Well, he gets involved. He goes, well, no, that's not true. Aren't you the adult here? So back off. And I said, well, we'll just put a visual schedule in place. You'll get all your stickers, and it'll be good. And the rest of the day went like clockwork. She needed to know what was expected, how it was going to go, and what the reinforcer was going to be at the end of the day. It's really important. And I always tell people, if you cannot control your emotions, how can you expect them to control theirs? We're the adults. We're supposed to be in charge, and it doesn't mean sometimes you don't lose your cool. But in general, if you are calm and consistent, your child will know, I can trust you, I know you know what you're doing, and I'll be okay with that. Shutting down is really common. So this idea that there's like nobody home, we've had several folks do it. Parents talk about it a lot. It can mean they're overstimulated, frustrated. They're too upset to give a response at that point. So stop talking to them. Just leave them alone. Let them get okay. If they're not safe, find a safe place for them to be. Find a way that you can kind of move them out of the flow of, sometimes it's happened in school. If they're in the middle of the hallway and they're about to change classes, maybe you find a way to kind of move them over to the side or whatever. But if you can't, they're like a pylon. People will walk around them. At some point, they're actually going to get up and get out of the way. But again, I think you have to anticipate problems and not just react. A lot of people are very reactive and they react to problems. I think you have to anticipate there's going to be problems, and this is the plan. Work the plan. Being calm and patient really is the key. When I see parents' affect as being pretty calm and patient, I find kids who deal better with day-to-day stresses. From the time they're very young to adulthood, I really say the key is consistent parenting, environmental supports, and planning. It is not a magic pill. There is no magic cure, but there are some pretty amazing things that day in and day out will shape and mold your child into a pretty successful adult. Again, you can plan, but you got to stay flexible. How many times have we were talking about flying up to Canada. Oh, your flight's been delayed. There's a flight thing in Chicago. We can't. I'm like, I could freak out about that, but there's no reason to. I can't control the weather. So you have to do those kinds of things and have really reasonable expectations of others. Sometimes people will say, well, the teacher, doesn't like my child, or the teacher won't do these things. I had a young lady who wanted her child in 9th grade. He was going to be taking algebra. I was pretty sure, having known him for this many years, he was never going to be able to get through algebra. I love what she said. She goes, but I want him to take algebra. I want him to get out with a regular high school degree. And I go, so is that what he wants, or is that what you want? And she goes, well, it's what I want, but that's the important thing. And I said, no, if he can't do the work, that's not really fair to him to have him sit in a classroom and basically go, what are we doing? And she said, yeah. I said, it's more important for him to have basic math skills, and I think you do have to work as a team and having realistic expectations. But again, realize you know your kid better than anyone else. So don't let people try to snooker you or tell you that you're not right, because I do think you know. And I think you have to have a sense of humor. The parents who do the best are the ones who can laugh and some of the crazy things that you never thought in a million years you'd be doing, but at the same time realizing that there were other people in the same boat as you, and it's really important to have a support network. Nurturing yourself. We have so many parents who will not take care of themselves, and I kind of tell them, you know, that idea that you got the oxygen mask, when it drops from the plane, you're supposed to put on yours and then put on your kids. They tell you that because if you don't take care of you, you cannot take care of them. So I tell you, nurture yourself. Think of things that you like to do, and people often say, I don't know what I like to do. I've been so busy parenting and whatever, but you have to nurture yourself, and if you don't, you will find that it's a marathon. Nobody gets to do a marathon by sitting on the couch for the 6 months before, just kind of going, wait, hey, it's Saturday, I'm going to get in there, I'm going to run to the end. You're never going to make it. You have to train, you have to plan, and you have to take care of yourself. Because again, some people will get on that treadmill and they wear themselves out and they don't realize you have to nurture you. You can totally revel in your child's successes. We have people who cannot see their child anymore as not being a mass of problems. There are some amazing things they can do. I think we need to revel in that. And I said, you know, if you don't do it now, when are you going to do it? So when they do amazing things, you got to appreciate how far they come. When you think about that doctor who told you, your kid's never going to do this and never going to do that, it's great. Send them a picture and go, well, you know what? He did do that. So I think we need to be really sure that we revel in those successes and enjoy them because they are so important. Find ways to cope with stress. You know, maybe I'd love to say I'm a meditation or yoga person. I have yoga mats that never have been enrolled. I'm not that kind of person. But if that's your gig, I think it's amazing. We've actually been teaching parents who have kids with different developmental disabilities meditation and mindfulness techniques and found that it reduced cortisol levels, stress levels, and depression amazingly well in just 8 weeks. So I tell people, find your thing, do your thing. I like to run. It's something that I enjoy, and I make time. And people go, yeah, but I go, I literally get up at 4:30 every morning to do it before my two, high school and middle school kids have to get ready for school. And that's what I need. And it makes a huge difference in day-to-day stress and how I feel. And if there's a few days I don't get out, I am the grumpiest mom ever. So you have to figure out what you like doing. Journaling for some people, book group, exercise, laugh. Laugh at things. Love Big Bang Theory is my favorite show. And if I had a bad day, I'll watch like 8 episodes, one after the other. Laugh, laugh, laugh. These guys are great. So I kind of feel like you need to do whatever it takes. Find support groups. A lot of our families isolate themselves because they say no one knows what I'm dealing with. Well, maybe they don't, but there are people that do. And you guys are in a room where everybody, they may not be in the same place and you may not be in the same point in your life, but everybody is dealing with something. And the best way, especially for people to deal with it, is to connect with others. Parents do play a key role. So it's not just genetics. There's a lot of environmental things and there's a lot of parenting. I'm going to talk a little about some parenting success stories and how to have a positive outcome. So Sophie is somebody that we follow and we just love her. She's 14, but her weight is normal. Her diet is healthy. Her mom decided that school was so hard for her because she was kind of getting lost in the cracks. She was actually doing well academically, but just wasn't getting a lot of extra attention. So the mom has decided to homeschool her. I'm not a big lover of homeschooling, but I can say for this girl, it is amazing. And the mom is an amazing teacher. This girl literally is doing so well. So now her big issue is getting growth hormone. The endocrinologist that she works with goes, she's tall enough. She doesn't need growth hormone. And I love the fact that this mom says, I am going to get her growth hormone if it's the last thing I do. And it's like, I love the fact that she's willing to fight for her. But again, balance is the key. You have to nurture yourself. You have to take care of the other members of your families, nurture your marriage, your other kids. You cannot over-focus on your kid with Prader-Willi Syndrome. They need to be part of your life, not your life revolving only around them. This is a really neat story. A young man that we saw at 9, morbidly obese, poor diet, no food restrictions. Mom didn't want to lock the refrigerator because, I shouldn't have to do that. Well, you may not have to do that, but you have to do that. So, and I love the fact that she goes, he won't exercise. He's an only child, by the way. She said he won't exercise. I put him outside and tell him to go exercise. I looked at that mom. I said, you need to get off your butt and you need to go play kickball with him or walk around the block. You need to do whatever you need to do to get him to exercise. Who exercises because your mom puts you outside and says, exercise? And so it's totally not going to happen. But now I love the fact that, she was having a hard time saying no. She couldn't set limits. And I kind of said, Mary, if you don't do it, it will not get done. She's a single mom. Now I love the fact that we saw him just a few months ago. He's 14. He's doing cheerleading, basketball. He is actually in a high school play. And it's like he is doing better. And he weighs less now at 14 than he did at 9. The mom locked the refrigerator, locked the pantry, and she said, you know what? I realized if I didn't do it, nobody else would. Parenting adult with PWS, a lot of people ask about life expectancy. We are seeing more and more adults who are in their 40s, 50s, and 60s with Prader-Willi syndrome. It blows me away how well they're doing. So again, if we can limit their weight to something that's relatively healthy, it does not have to be super skinny. It just has to be healthy. Then I feel like they can actually have an average lifespan. And again, there's a lot of varying levels of independence, and the fact that Jacob talked about that is really cool. I think we need to tailor the environment to their level. And it's not just cognitive level, it's actually how independent they could be. For some, behavior definitely gets better as they seem to get older and it seems to mellow. And again, we're finding more and more adults who are gaining new skills, new independence as they get older. That blows me away, and it is such a cool thing to see. The challenges, I think, are things like relationships, vocation, supervision, family life. What would it look like for this guy to be more independent? Those kinds of things. We need to look at that and figure that out. A lot of people ask, can their kid with Prader-Willi syndrome live on their own? We don't follow anyone who's completely independent, but some live pretty semi-independently and have supports. Joe and Catherine, he's actually a local guy, and I've known him since he was 15 years old. He's now 34, and he has been married to Catherine for 4 years. I went to their wedding, and literally my daughter brought an entire purse full in her little purse of tissues because I bawled like a baby. It was the sweetest, most touching thing that I've ever seen. And actually, after he danced with her and his mom, he actually picked me to dance with because he said, I feel like you have seen me struggle and you know how far I've come. And I even now, I still stay in touch. We're going to have a meeting in a couple weeks at the zoo. And Joe is always my big ringleader. So again, but they could not do it without the support of their family. There's no way that they could live like they do. So there's things to consider. Money access, transportation. Joe actually does have a car. If his weight gets over a certain amount, the keys are gone. It's kind of like confession. He literally, I see his number on my caller ID and I go, hey, Joe. Yeah, I lost my keys. For anyone else, that would mean you don't know where your keys are. For Joe, it means I got over my weight limit. I had to relinquish the keys. So for him, that's what he needs. His mom delivers his meals every day. He was at Pittsburgh. It's been an amazing experience for him. He's lost 250 pounds. It's been so cool. But I love the fact that his mom delivers his meals and his wife's meals every 2 or 3 days, either in white bags, has Joe's name on it, Catherine's name on it. And I love this. This is like a Prader-Willi mom. One day, Joe just curious, what has Catherine got in her bag? They're always sealed up. I never get to see in there. So he very quietly, and Catherine has a vision impairment, so she cannot keep control of his food. She can't see more than 2 feet in front of her. So he opens it up, and there's a card inside. It says, Joe, this is Catherine's food. It is not yours. He rolled it back up, closed it up, and hasn't looked to this day. So it is pretty amazing to me. She knew it was going to happen. And again, the decisions aren't easy. You have to decide quality of life and independence level, and it's different for everybody. I'd like to say there's a formula. There's no formula. Lifelong supports. You have to kind of see as things change, you need to change. Focus on independence, but know that what can they do for themselves and what will they need support for. Focus on life skills and social skills, because to me that's the biggest predictor of who's going to be okay in the real world. I'd like to say that it's cognitive abilities or whether they can do algebra. Amazingly enough, no one has ever asked me to do algebra since I left high school, so thank God it's not something that's required. So you need to figure out what that is, and you need to figure out when to step in. One size doesn't fit all. You have to take care of your needs too, physical, mental, and you have to let go a little bit. Some people will say, well, I can't trust anyone else. You have to have people in your life that you can trust with your child, respite, support, whatever you need, and you have to trust yourself to do what's best for your child. Sometimes it's not easy, but it has to be done. And again, to realize that, it's okay if you're not the perfect parent. Nobody is. What's good enough some days is okay. Consultation help, there's some amazing resources. Again, crisis, through PWSA. There's also things through FPWR that I think really helps people. Pittsburgh is really an amazing organization for people who need inpatient hospitalization. And again, try to figure out your state organizations and other kinds of things that will help you get support and training to kind of figure out what you need to do. The families that we see are so amazing, and honestly, we could not do it without you guys. It is amazing to me to see how successful we're seeing more and more people being these days. And I kind of feel like from the littlest to the people that we see are the oldest, it is amazing to see what you can accomplish. And again, So much of it is what you're willing to do and what you are doing day in and day out. So I know it's hard. We've had several people say it's just so hard. I can honestly say, though I don't live it every day, I hear it every day, and I know how hard it is. But realize you're not alone. There are people who want to see you succeed. And because you know some of these success stories, I really feel like it's something we can actually make happen. There's a tip sheet that Lauren's going to hand out, but I would be glad to take any questions that people have. Anybody? Well, yes, Stephanie. How come I knew it'd be you? Mm-hmm. No, actually, it was an alarm for their door. So, but some people, the lock, I would assume that there probably is some, yeah. No, it was something she ordered off Amazon. It's like a contact alarm. It has something you like almost like double sticky tape you put on the top of the door, and it basically touches each other. And the minute it's open, it goes beep. So she said it was just something she bought. It's completely battery operated, so she didn't have to worry about that thing. And at the end of the trip, she pulled it off. Yeah. See, I knew somebody. No. Home Depot, Lowe's. Like pool gates, yeah. Oh, yeah. Is that what it is? Yeah. Come on, show us what it is. That's cool. It's like, now it's not working. I get that. Is it loud? Oh. That'll wake you up. Yeah. Mm-hmm. Mm-hmm.
I have a 9-year-old daughter, Carly, and we recently just, in the last year, started her on, after trying several different, over the course of several years, several different behavioral approaches, or behavior, all different. And it just didn't seem to be improving.
Mm-hmm.
And so we started her on an SSRI, and then recently added an antipsychotic. And two comments I just wanted to tell three. The first one is the antipsychotic is such a low dose that the pharmacist is actually asking for this in an animal. To which I answer under my breath sometimes.
But the second comment I wanted to make about it is that, it was something I kind of figured that by teen years I had heard and knew that it wasn't uncommon to, have to supplement some of the behavioral strategies with medication. And it was a hard thing for me to get to that point, to give it to someone so young.
Yeah.
And I have to say, my only regret is that we didn't start sooner.
A lot of people say that, and we've had several people that we've suggested medication, and they're so funny. They're like, "Oh, I'm not there yet." About 3 months later, they'll call me and go, "I'm there." What was it again? Okay. So I think
sometimes
it is. And my thought is we talk a lot about them. They're so young and they're whatever. But we've actually had kids who've actually told us. We had a young man who started an antidepressant, and I love what he said. He goes, "Elizabeth, I feel like I'm going to be okay." And I thought, wow, the fact that he felt like he was going to be okay was huge, and he actually realized what a difference it made in his behavior.
Oh, and she's on a very low dose of both, and actually she's on Prozac. We did try the other one, but Prozac seemed to work better.
And that's the thing. There's so many individual, variances as far as medication goes. So I tell people, if you know of other family members where a medication works, that's a really good place to start. But I feel like for a lot of times you have to try multiple ones. So don't think it's a magic.
That was going to be my third comment to anyone that is, not that everyone gets to that point. I mean, some people never do.
Yeah.
But it can be a lengthy process. So I think, I was really sort of aware of that, so it didn't
But
bother me.
the once and done, a lot of people will say, I tried Paxil, didn't work, I'm done.
Yeah.
There are other things you can try.
It took
and I
us
think
about a year to find
Okay.
the right one.
The right
and
one
again,
and the
it's
right
one
dosage.
at a time,
Yeah.
right? And so anyway.
That's great. Yeah. A lot of people ask me about that, and for a while, there are a few things that work. We don't have a lot of people on them, and sometimes the dosages that they require, like a lot of people, SAMe is something that's actually a supplement that you can buy. It's been shown to work for like low-level depression, so it may work in this population. What's so interesting is because the dosages that it requires are so like big, like you have to have like 3 or 4 pills versus like 1/4 of a, Prozac or something. It's sometimes really not cost effective. Sometimes it costs 4 or 5 times the amount to supplement versus the smaller dose. So not as much, but I tell people a lot of people have tried other kinds of things. We have people who've used valerian root or something like that for like that agitation. It seems to be okay. It just seems to be very variable. So my thought is there's probably the idea that you could use it, and there's some indication in regular children that like SAMe works, but again, we know very little about it in kids with disabilities. So I wouldn't say I don't know much about it. We saw a few years ago a lot more of it. A lot of people have actually switched from those to medication because it just wasn't enough. Anybody else? Yeah. Mm-hmm.
If they say that she doesn't need it anymore, should she still have it on there, or is she just not bothered by?
I think a lot of people will say they don't need it anymore, and the deal is they still need it. And I kind of feel like, we talk about behavior modification, like we put something in place, we alter the behavior, we change it for good, and we're done. I don't say behavior modification. I actually say behavior management. I think it's day in and day out, and you can all relate to the fact that what you do day in and day out, it's not like one day you go, oh good, we don't have to do that anymore. You have to keep managing. And people talk a lot about the behaviors going away. And I always say it's like water running downhill. You do this, you do that, and then you find somewhere along the way there's a little breakthrough. And I think the idea is if it works well, it may be a little extra work for the teacher, but I feel like they sometimes need that just constant reassuring. And that's also a way to get questions done and answered. Because I tell people, look at the schedule. What's on the schedule? Schedule. And you keep cueing them back to that. So you don't have to answer, when are we doing spelling? When are we doing our spelling sheet? And a lot of people find that it's a lot less work to go, schedule, what's on there next? And they can actually do that. So you shouldn't answer the same question over and over. So I kind of feel like if you think it would work, override the teacher.
They're trying to teach her independency.
I think a lot of people have this idea that, oh my gosh, one day we will teach them and they will be so independent and they won't need these supports. I do not find that to be true. All of our adults have some level of supports and some level of this kind of idea that we help them shape and model their behavior. And for each new environment we put them in, we come up with new strategies to work in each environment. Not that we teach them and they learn it and they're done. I just don't feel like we can do that with them. I don't think it works. It is. And I was going to say, and what you see that is, and there's something there's actually a workbook that's on our tip sheet, and I love the first exercises. Where do you see your kid's life is going? Like, where do you see them being happiest and independent? I think for each person, you have to answer that individually. And for a lot of people, they will often say, I want my kid to be happy and content and to have a life that means something. I think we can do that. It may not mean that they live on their own and they drive a car and they have their own apartment, but is that really what they often need to be happy? No, they want to be safe and they want to have things that matter to them. And I do think it's so individual, Tanya, that you have to look at that kid, that situation. And if your kid has a lot of maladaptive behaviors, then my thought is we need to deal with those and not necessarily the academics. We have a lot of people who focus on academics, but the kid can't even stay in the classroom for a day, a week, or whatever at a time. Then we need to focus on the behaviors to keep them in the classroom, not the let's do 4 more math worksheets and it'll all be good. I think we have to focus on what's relevant at that point. Good. 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 And that, yeah. Good, good. Rhea?
Yes.
You're going to have to talk louder.
My son, one of the problems we have with him is when he has his issues and he's like shutting down and he's crying. I feel it really difficult, like when I try to give him sort of regular consequences at that point, which I know needs to be done. I don't know if it's, I don't want to say it's cognitive, but it's like he's having so much trouble that he's shut down.
Yeah, I don't think the regular consequences at that point work. I tell people, when you sit there and go, I'm the parent, I have to make that. No, it doesn't work at that point. I think you put him in a place where he can kind of get it back together, and then the consequences can come, and they don't have to come at some later point. But I think the idea is if you do them then, you're only going to make them more upset, and it's not really going to stick.
Well, and he's not going to learn.
No.
It's not going to prevent him
from doing it again
next time, which is what I have trouble. However, he's 7 now.
Yeah.
I'm concerned when he has problems or issues, and if hitting or something comes up, he doesn't necessarily do that at home. He has done it a couple of times at school.
Mm-hmm.
But I'm like, well, one day he's going to be 10, and one day he's going to be 12, and one day he's going to, and it's not going to be so. No, we're not going to be able to deal with it. So I guess.
Well, I think it's identifying the triggers in a situation. So I just went into a school where a girl is being restrained almost daily, and they're like, we think things are working pretty good. Really? Restrained every day, and you think it's good? But the deal is they aren't identifying the triggers that cause her to go off and hit or pinch or whatever. And I kind of laugh because the person she's more likely to attack is the teacher. And it's like, what are you doing? She's like, well, I'm trying to restrain her and contain her. And I say, I've been doing this for 20 years and I've never had a hand laid on me. And it's because when they get upset, I don't get too close to them. That's stupid to me. So I think you have to be really careful about that. And the idea that you pick and contain and squeeze them, I don't know. They feel like they're very threatening. They take that as a personal threat to their safety, and they get whoever's close enough. So I think you have to be careful about that. And a lot of times it works better to stay out of their space and let them to de-escalate at that point.
Okay, we've actually got 40 viewers remotely who are watching online, so we've got
wow, that's so cool.
A couple of questions from them. So
I can barely operate PowerPoint, and you guys have this thing going. I'm like, wow.
We've got somebody who's asking if how risperidone works for violent behaviors.
It's kind of an interesting drug because it's used, like I said, as an atypical antipsychotic, but it does seem to soothe and smooth impulse control. So when you get upset, it seems to kind of calm that impulse to hit, to lash out, to be verbally aggressive. And like I said, incredibly small doses seem to really smooth out that irritation. So it helps with the impulse control that goes along with aggressive behavior. Because for a lot of people, once it's over, they're kind of over it. But it's that impulse to do it at the time, I think it really curbs with that. And like I said, the doses that we're talking about are incredibly low. So it just seems to work to kind of help with that impulse control.
Okay. And the last one we had was just if you could speak to attachment issues in some of the older kids. Somebody said they have a 24-year-old son who has attachment issues, and when she leaves, he breaks out in cold sweats and things like that.
So he's pretty dependent on his mom, right? So I would say a lot of it is dealing with some of this before they get to be 24. A lot of people will say, my kid has never spent the night away from home, my kid has never been away from me, and I'm like, no. You have to work to make that happen. So I would actually say that doing it for small amounts of time, to keep making the time longer, to kind of do the behavioral issues is really important, and to also find people that can step in and he can trust who can take care of him. And that's where a lot of it comes. Mom, I can trust. These other people, not so sure. So I kind of feel like, and a lot of parents actually unwittingly do these things. They make you only trust them because I'm trustworthy. I think you need to find other people to step in. So I would say he'll be okay, but she needs to find a way to slowly but surely make that time that she's away longer, and that people will take care of him. That's really important to find people to do that, because you don't want to be hospitalized or need to be away from your child before they spend some time alone. I think that's really important.
Great. I think that's it for.
How much should I try to redirect when she obsessively plays with something?
So things like timers work really well, so you can give her a certain amount of time that she can play. I kind of feel like some of the obsessive playing, like at the end of a school day especially, a lot of kids need a decompression time. They want to do something around repetitively. Let them do it. But if it actually coincides and they can't interact with the real world, or they're doing that over interacting with the real world, that's actually a problem. So limiting it, containing it, you can do it for this long until the timer goes off. And then you have activities that she would enjoy also at the end of that to kind of get her to transition.
So I should try to redirect the play or to limit
It's okay to do it for a small amount of time, but not over and over to the exclusion of everything else. So I tell people, if it starts to rein in on family time or other activities, then it's a problem. And you'll know that, where that is.
Okay, I think we're done. Thank you
Awesome.
so much, Elizabeth. Before you run away, we have a quick thank you gift. We appreciate you and your team coming out and meeting with us. And you're always such a joy, so thank you so much.